Good afternoon. I can see we are all excited. Okay. Good afternoon. I can see we are all excited. And it's good to be excited. Welcome back once again. So today we are going to be looking at multiple myeloma. Okay, multiple myeloma. But before we do that, we'll be looking at the broad category under which multiple myeloma falls. Okay, and that category we call it paraproteinemia. So from the word paraproteinemia means in the blood, in circulation. Paraprotein in what? Circulation. Are we getting that? So when we say paraproteinemia, what comes into mind? What comes into mind? Yes, anyone? So paraproteinemia refers to the presence. It refers to the presence of immunoglobulins in circulation. Presence of immunoglobulins in circulation refers to the presence of immunoglobulins in circulation produced by a single clone of plasma cells. Produced by a single clone of plasma cells. You know, we say paraproteinemia, paraproteins in the blood, in short. But what paraprotein are we talking about here? The immunoglobulins, okay? The presence in circulation of immunoglobulins, or the presence of what? Immunoglobulins in circulation produced by a single clone of what? Plasma cells. When you say single clone, together we say that is monoclonal. Exactly. Are we getting that? All right, let's move ahead. Now let's talk about the differentials or the causes of paraproteinemia. We're looking at 6 of them. The first one is multiple myeloma, which we'll be looking at today. Multiple myeloma. And we should know that in multiple myeloma, the dominant immunoglobulin is what? G. Immunoglobulin G is the dominant. Okay? This is what is dominant. Meaning that if we take 2/3 of the cases of multiple myeloma, the circulating paraprotein will be of what? The immunoglobulin G type. Immunoglobulin G. Okay? Are we getting that? Okay. We'll talk about this, so we will not waste time. The next one is what we call the Waldenstrom macroglobulinemia. Waldenstrom. Waldenstrom macroglobulinemia. Also known as lymphoplasmacytic, or if you like, you can say cytoid or plasmacytic lymphoma. For this one, the dominant immunoglobulin will be immunoglobulin of what? The M type. Immunoglobulin M. And clinically, you will see the Waldenstrom macroglobulinemia being characterized by splenomegaly and hepatomegaly. When it comes to the treatment of this, Either you are using a single or combination therapy. Which drugs are involved? You think of fludarabine and also chlorambucil. Think of what? Fludarabine and what? Chlorambucil. Either you are using them alone, not single therapy. Either you are using fludarabine single-handedly, or you are using chlorambucil single-handedly, or you are bringing the two of them together. Please, are we clear on that? All right, let's move ahead. The next one is what we call monoclonal gammopathy of undetermined significance, MGUS. Okay? Monoclonal gammopathy of undetermined significance. That's MGUX. So for MGUX, what are you going to be finding? You will see that it will be characterized by, if you do a bone marrow biopsy, you will have less than 10% of plasma cells seen, less than 10% of plasma cells seen on bone marrow biopsy. Should you check the paraprotein levels? This is what you are going to have. You would be seeing that the paraproteins, the serum paraproteins, or we can put monoclonal, serum monoclonal paraproteins. Serum monoclonal paraproteins will be less than it should be less than, what should be the threshold? It's what? If you say 3 grams, no. It should be what? 3 grams. Yes. So you should bring the deciliter. So when we say 3 grams per liter, that is more like 30 grams per deciliter. Do you get the point? Okay. So it should be less than what? 3 grams per deciliter. And also, for monoclonal gammopathy, there is no multiple myeloma related end organ damage. And in this case, we'll be thinking of which end organ damage can we think of? Hypercalcemia. You can think of anemia, and you can also think of renal failure. Did we get that? Did we get that? Are we getting that? Okay, so if you see these characteristics, you'll be thinking more of what? A monoclonal gammopathy of undetermined significance. Is that clear? And monoclonal gammopathy is a stage of progression in multiple myeloma. It is a stage of progression in multiple myeloma. The next one The next one, we are thinking about primary amyloidosis. Primary amyloidosis, the main or the major amyloid that you see is which one? We call it what? The AL amyloid. Okay? Are you following? These will be deposited in the kidney and can precipitate a kidney injury or renal injury. Is that clear? Are we following? But let's comment on amyloidosis in general. Amyloid is a form of protein. Okay? Amyloidosis, if you are talking about amyloidosis, there are 3 types. Yes, who can tell us? There are 3 types of amyloidosis. Yes, go ahead. The primary, and the what? Yes, what's another name for the familial? We also call it the familial amyloidosis of the finished type. Or if you want to go for further studies, then you can say familial transthyretin disease or familial transthyretin what? Amyloidosis. Exactly. Do we understand? Oh, we are over here excited. We are over here excited. Okay, that's good. So let's take note of that. Once it's written, you can see, and that will be good. Visual plus what? Hearing. Visual plus audio makes a better sense than just any of them. Okay. So we have the primary, as we were saying, primary amyloidosis. And we say for the primary, the amyloid that would be produced is the AL amyloid. Then we also have the secondary. The amyloid that will produce will be of the AA amyloid type. Then we also have the familial, which is said rightly, familial amyloidosis of what? The finished type. Finished type, as if Finland. So we call this one the FAF. This is what we call the FAF, okay? Are we getting that? Another name for it, we can also call it a familial transthyretin amyloidosis. That's FTA. FTA. They also have FAF. Okay? These are the types of amyloidosis. For this familiar one, mostly it will be due to a mutation in the transthyretin receptor gene. Okay? A mutation in the transthyretin receptor gene, and can be what? Inherited. That's what we are saying is familial. It is autosomal dominant. It has an autosomal dominant type of inheritance. Is that clear? Please, are we clear on that? Yes, all right, let's proceed. So that's for the primary amyloidosis, also being a differential, of course, of what? Paraproteinemia. The next one, we'll say paraproteinemia. Paraproteinemia in lymphoma or leukemia. Paraproteinemia in lymphoma or leukemia. Okay? Then again, we talk about the heavy chain disease. Heavy chain disease. For the heavy chain disease, one type or one subset of it is what we call the alpha chain disease. Alpha chain disease. And do you know what alpha chain disease does? Okay. The alpha chain disease infiltrates. It infiltrates the walls of the bowel or the walls of the intestine, destroying the macrovilli. You know what the macrovilli is? Please, what is the function of the macrovilli? Aziz. Macrovilli, what does it do? First of all, what does it do? Yes, Michael. Excellent, well done. So it increases the surface area of the intestine, allowing for what? Maximum absorption of what? Nutrients. And you see, when you go to the small intestine, you see that they are a lot there. They kind of expand the surface area for absorption. Okay? So they infiltrate the walls of the intestine, destroying the microvilli, hence inhibiting what? What is inhibited? Absorption, yes. Absorption. So by so doing, we can infer from these that the alpha chain disease causes what we call IPSD, which stands for immunoproliferative small intestine disease. Exactly. Immunoproliferative small intestine disease. Immunoproliferative small intestine disease. Exactly. Please, do we understand? All right, that is good. I like the way each and everyone is trying to pay attention and to take note of what the valid points being raised. All right. Okay, that's fine. Now let's move ahead. So these are the causes of paraproteinemia. So if they talk about paraproteinemia or high levels of paraproteins in circulation, think about this along this lane. And depending on the specific content, then you can zoom in onto one of them. Okay. If I say which of them is associated with paraproteinemia and at the same time malabsorption, what will you go for? That will be what? Heavy chain disease. Exactly. Please, are we clear on that? Okay, now let's move on. Now that we have established all that, let's move to multiple myeloma, MM. MM. So first of all, you should know that multiple myeloma is considered as the chief plasma cell dyscrasia. When we say dyscrasia, what comes into mind? Dyscrasia is an abnormality of what? The blood. Abnormality of the blood. Where do you find plasma cells? Plasma cells, where do you find them? Where are they produced? They are produced in the bone marrow, true or false? What's the difference between the B lymphocyte and the T lymphocyte? Yes, anyone? Yes, go ahead.
Where they mature, the B lymphocytes mature in the bone marrow, and then the T lymphocytes are migrated to the thymus to mature.
Yes, that is correct. That's why we call it the T and the B. B arises in the bone marrow. The T lymphocyte, they arise from the bone marrow, but mature in the thymus. So that's why you say thymus it belongs to the immune system, true or false? It's true. The spleen belongs to the immune system, true or false? Yes. You will be speaking in that direction. That is correct. Okay, let's move ahead. So we are saying that multiple myeloma is the chief plasma cell dyscrasia. Okay? Now let's define multiple myeloma. We are going to give two definitions. So the first one, multiple myeloma is defined as a plasma cell malignancy. It's defined as a plasma cell malignancy in which there is an abnormal proliferation of a single clone of plasma cells. Let's take it again. In which there is an abnormal proliferation of a single clone of plasma or lymphoplasmocytic cells or single clone of plasma, or lymphoplasmacytic cells, resulting in the production of an immunoglobulin, or an immunoglobulin fragment, causing dysfunction in many organs, especially the kidneys. Telling you that the most commonly affected organ when it comes to multiple myeloma is what? The kidneys. That is why when you go for an exam, they ask you, what is the most common cause of death in a multiple myeloma patient? What will you say? Kidney disease or renal failure. And in addition to that, you add infections. And why infection will come there, and we'll talk about it. Okay? All right. So that's the first definition. Let's look at the second definition. So the second definition, it can also be defined as a plasma cell malignancy. It can also be defined as a plasma cell malignancy in which monoclonal plasma cells proliferate abnormally, in which monoclonal plasma cells proliferate abnormally, resulting in an overabundance of monoclonal paraproteins, the destruction of the bone, and the displacement of other hemopoietic cell lines. A plasma cell malignancy in which monoclonal plasma cells proliferate abnormally, resulting in an overabundance of monoclonal paraproteins, the destruction of the bone, and the displacement of other hemopoietic cell lines. Again, a plasma cell malignancy in which monoclonal cells proliferate abnormally in the bone marrow. Please, let's add that. In the bone marrow, okay? Proliferate abnormally in the bone marrow, resulting in an overabundance of monoclonal paraproteins, the destruction of the bone, and the displacement of other hemopoietic cell lines. Please, are we clear on that? Are we clear? Okay, let's move ahead. Let's talk about the epidemiology of multiple myeloma. Epidemiology. You should know that for multiple myeloma, the male to female ratio was approximated to be at 1:1, but further studies going into detail reveals that male have an upper hand with regards to the incidence to the female. So the ratio is equivalent to 1.54:1. In some jurisdiction, depending on the geographical location, there may be variation, but in multiple myeloma, the males will dominate. So if they are going to bring a case in multiple myeloma in your exams, they could preferentially go for what? A male. Similar to what? The SLE. You go for what? Because barely would you be seeing a male developing SLE. Rather, female is preferred. But here, you realize that it's just a slight difference. So male and female can develop, but the male have the upper hand. Is that clear? Now, again, you should know that multiple myeloma is more common, again, in the African race. So if you take the Caucasian or Americans or whichever ethnic group, you realize that the African race would always be having the populous, we populous when it comes to multiple myeloma. Okay? Then again, the peak age of incidence of for averagely is 70 years. In some other jurisdictions, they'll pick it at 69 years. But if you are going with what? Tens, you go for 70, right? But remember when we were talking about SLE, we said for SLE, it is what? 20 to 30 years. But, 20 to 30 years. But is what? 70 years, averagely. That's the average age. Peak age of incidence, 70 years. But it doesn't rule out the fact that if you have a male who is younger than that, presenting with features of you will not say that So in that case, you should note that a male patient, a male greater than 50 years, presenting with bone pain or back pain, suspect multiple myeloma. Suspect multiple myeloma. So if you have a male who is greater than 50 years, presenting with bone pain or back pain, please suspect multiple myeloma. Exactly. So the 70 years that we gave was average. It means that if you have like let's say 50 to 90 years. That's range. If you add 50 to 90, you get 140. Divided by 2, what will you have? 70 years. So that is the median age. The 70 years that we are talking about is the median age. Okay, let's put there. Median age. Median age for multiple myeloma is the median age. Is the median age. Please, are we clear on this? Are we clear? Now let's move ahead. Let's look at the pathophysiology, like the progression. The pathophysiology, we'll be looking at what? The stages of progression of multiple myeloma. We'll be looking at 3 of them. Okay? So stages of progression. So there are 3 stages. So the first one is the MGUS, you remember? Monoclonal gammopathy of undetermined significance. That's the first one. Okay? Then it will progress to what we call the intermediate between the monoclonal and multiple myeloma, intermediate disease, which we also call the smoldering Or we also call it the what? Intermediate disease. Then the last one is the multiple myeloma itself. So now let's look at the features under each of them. Okay. If we take the monoclonal gammopathy of undetermined significance, we said a lot of things there. We said for it, you are going to have less than what? 10% of plasma cells on what? Bone marrow biopsy. Okay? On bone marrow biopsy. Then we also said the serum monoclonal paraproteins or the serum paraproteins. The serum paraproteins okay, let's put it this way. We'll say paraproteins, okay, less than 3 grams per deciliter on serum or urine electrophoresis. Serum or urine electrophoresis, it will be less than 3 grams per deciliter. Then the last one that we said, no multiple myeloma related end organ damage. And we said the end organ damage here, we can think of what? Hypercalcemia, anemia, and renal what? Renal failure. That is true. Renal failure. Please, do we understand that? Do we get that, please? Okay. When you come to the smoldering multiple myeloma, you are going to have the plasma cells greater than what? 10%? 10% of the plasma cells on bone marrow biopsy. Then the paraproteins here will be greater than or equal to 3 grams per deciliter on serum or urine electrophoresis. Then the last one again, the only difference here, as you can see, is that the differences here is that the number of plasma cells is increasing as you move towards multiple myeloma. So here is increase. The proteins will increase because which cells are producing the paraproteins? It's not the plasma cells. Please, are we getting that? So if it tells you that the density of plasma cells is directly proportional to what? The mass of what? Paraproteins produced. The higher the plasma cells, the greater the what? The mass of what? The proteins produced. Is that clear? So here again, smoldering multiple myeloma, since it's not multiple myeloma, you don't expect any end organ damage, right? So there will be no multiple myeloma related end organ damage. And we know the end organ damage already. Hypercalcemia, anemia, renal failure. Then we come to almighty multiple myeloma. Here, the plasma cells still will be greater than 10%. There will be greater than 10% of plasma cells on bone marrow biopsy. Then again, the paraproteins will be greater than or equal to 3 grams per deciliter on serum or urine electrophoresis. Then here, the only difference between the smoldering multiple myeloma and the multiple myeloma itself will be what? The end organ damage. So here you are going to have multiple myeloma. So all along we've been waiting for this. Okay, multiple myeloma related end organ what? Damage. And we know the end organ damages. So we should add them there. Hypercalcemia, anemia, and what? Renal failure. Exactly. This is exactly to you. Exactly. Okay. Now again. Are we done? Can we move? So the next thing we are going to be looking at is, when we're talking about paraproteinemia, I showed you that in multiple myeloma, the dominant immunoglobulin is what? G, right? So we are going to look at the frequency. How, out of 100 cases, how many would come with what? Immunoglobulin G? And how many will have the others? Okay? This I believe I can erase. So, in multiple myeloma, as we said that for multiple myeloma, immunoglobulin G will be present in 2/3 of the cases. 2/3 cases. Okay? And immunoglobulin A will be present in only 1/3 of the cases. In rare cases, you will see immunoglobulin D and immunoglobulin M are present in rare cases. In rare cases, you have these present. Place is that clear? Now let's move ahead. The next thing we want to look at is the clinical presentation. Okay. When it comes to multiple myeloma, there's a trick around the whole stuff. Always remember CRAP. Okay, CRAP. C-R-A-P. CRAP meaning carcinosis, renal failure, anemia, and what? Bone pain or back pain. And when it comes to these 4 things that we mentioned, bone pain or back pain is the most common presentation in what? Multiple myeloma. That's why I told you that if you have a male who is greater than 50 years presenting with what? Bone or back pain, suspect multiple myeloma. Is that clear? So if you go for an exam and they are going to give you multiple myeloma, look for CRAP. It will be there. They will not tell you carcinosis directly. They will say serum calcium measured so and so. Or serum calcium levels were elevated. They will say that the hemoglobin is less than 7 grams per deciliter. Or they will even say that patient complains of backache. 52-year-old male. What do we think of? Multiple myeloma. Okay. Now,